thank you. I know that we had some.
Oh, yeah. It's nice. Find any other exceptions for 65 plus? We do have 65 plus Medicaid.
Yeah, I think there was a couple.
I don't know if those are just the dual members who get full Medicaid benefits. There are 2 types of duals.
Yeah,
Make it even more confusing.
so the big thing that we're, papers. So those are numbers that we did not anticipate through the first year, so now.
So they're coming off Medicaid and they're applying it for senior. So, you know, as the program becomes more known,
Oh, it's something I learned. So I didn't realize how much it was applied.
Hello?
Hi, this is Dr. Bob.
Hi, Jill, how are you?
Good. How are you doing?
Good.
Yeah, we have.
All right, well, welcome everybody. Nice to see folks, we have new members here. So I think what we'll do is start by just going around the room and introducing themselves. And if there are new members, maybe tell us a little bit about yourselves as well. So I'm Linda Rayner and Sharon.
I'm Wyatt Johnson. I'm the Associate Dean of Clinics at the School of Dental Medicine. I guess a little bit of my background is, I've been in Colorado for 30 plus years teaching periodontics. So have in one way or another been involved in the treatment of many of these things.
I'm Todd Coffey with the State Joint Aging with the Department of Human Services.
My name is Julia Skins. I'm a Tri-County Health Department Dental Clinic. I'm new. Thank you for having me. I'm a hygienist. I treat seniors every day.
Hi, I'm Alan Kislowitz, and with the healthcare policy and financing, I manage the Medicaid and CHIP dental.
Chandra Patel, I'm the Senior Dental Program Administrator. I'm Nancy Wilson, also with the department. I'm the Social Financing Division. And Jill, who's on the phone, could you introduce yourself, please?
Yeah, my name is Jill Elfman, and I'm the manager of disability research and the
Great. Since we have kind of a small group in the audience, would people mind just introducing themselves to know who's here?
Hi, sir. My name is Dr. Carlson. I'm the Some show, dental director is here.
Hi, I'm in policy division at Colorado Community College.
I'm also in policy and you are?
I'm Tracy Gonzalez with the department.
Great. And our last person in the room, could you introduce yourself?
Like what? Yes.
All right. So, does everybody have had a chance to put our minutes? We have a motion to approve.
I'll move.
Second. So, Ellen, you want to say second?
Yes, I said.
All right, all in favor? Opposed? Okay, thank you, Linda. First, as you all are aware, the Medical Service Board passed our final adoption for the revised senior dental program rules, and those were effective November 30th. I would like to give this committee a huge thank you for your time and effort with helping us get those passed. In the last dental advisory committee meeting, there were 2 items that we wanted to put on the back burner until the rules got passed, and those were the discussion of exceptions and a database that providers could get in and look to see if the client that was newly coming in had had any past visits with other grantees. Now, before I have you guys do the discussions, since we have a couple of new members, I just want to let you know that the Dental Advisory Committee's role is to give recommendations to both the department and the Medical Services Board on policies for the Senior Dental Grant Program. So I will go ahead and turn this back over to Linda so the discussion can start on the exceptions. Do you want me to go a little bit more okay, from memory? Yes, a lot of history would be great. Yes. Some of the exceptions that have been brought forward are, let's say, a full mouth x-ray. We have some grantees that are stating that if they have cancer patients, it changes, and I'm not a dentist, so excuse me, it changes their mouths quicker than somebody who does not have cancer. So they would like to have an exception to giving a full mouth x-ray more than once every 5 years. Another one would be with individuals that need to, the teeth are not holding the fillings like they should because of the illnesses that they have, and being able to fill those teeth more often than what the current policy says. So those are kind of, at this point, we don't have any type of exception of if they contact me. I think there was once I contacted Dr. Wiley regarding a situation, but there is no policy on how exceptions are handled. So that's where we're at with this. So does the department have a suggestion for how you would like to handle exceptions? Well, what I have to say on this is this has to do with our current funding. Our current funding right now, we only have $1 million left for the rest of this fiscal year. I sent an email out to all grantees finding out who's still accepting new patients, and we only have 6. The rest of them have a waiting list. They cannot take any others. So the department's feeling on this is if we start getting exceptions at this time, we're going to be running out of even more money quicker. So, and I don't know if you have anything to add to that. And the fiscal year ends in June? Yes.
The other thing I would add, I think that we discussed this a little bit before, is that with the nature of the grant program, we don't have the resources to be able to have like a prior authorization process, to be able to have a clinician reviewing cases to see if they would be applicable for an exception. So if we were to have some kind of exception process, then we would certainly need with this committee to define some guidelines. But it'd be very challenging administratively. We're about halfway through the second year of our grant program. So of course, at this time, I guess I would say until we don't have any requests for exceptions beyond the benefit limitations that we currently have. We receive it, we're able to just to cover. Of course, as time goes on, that may increase because some meetings are limited to once every 12 months or every 5 years, that type of thing. So I think, to your question, right, I think the department's position is that we don't have the resources to have the expertise to guide this, and with the limited funding available, we will challenge whether the funds are sticking within the service limitations are not available.
Question. Is there a limitation on, in individual radiographs?
There is, I'm sorry, do you mean as far
Well,
as?
let's say it is, I understand why they may want to take the full amount, but there isn't any limitations on, say, hey, this tooth's bothering me, I can take a single radiograph.
Yes, they can do that. It's just certain radiographs like a full mouth and, yeah.
Okay. I mean, funding is limited. The ability to take a couple single radiographs probably is adequate, I think. But the one that it really bothers me because being a prosthodontist, I might have a much more geriatric patient pool, and I haven't seen exactly what you said. There's a change in health. All of a sudden, they're on different medications. They get dry mouth, and I mean, it is a battle to keep their hygiene anywhere near what it needs to be. And asking some of these restorations that really are bonded to a tooth the whole 5 years in that environment, it's probably not going to help.
I think, and just to clarify, I believe that our policy is every 3 years.
But, you know, one result maybe is the patient starts losing more teeth, and then you have to do a partial denture, and then you have to do a denture. And that's more expensive than replacing it with filling.
So I think another issue with the exceptions is it's not going to be applied equally around the state. So if you're in an area of state that's already spent all their funds, there's not really an opportunity for an exception there unless you're going to divert funds from another region. So I think there's another more fundamental question of how wait lists are managed, what criteria people are using for those wait lists, and is that consistent throughout the state? Is there a prioritization that happens with wait lists?
That's something that the grantees, when they actually signed up for the program, that we indicated to them that since there's limited funding, that there needs to be some type of priority when the patients come in. Unfortunately, I think with 1 or 2 of them, because of large amounts that have been spent, I am concerned that that's not happening.
So if a region that spent all of its money had an exception, would there be a way to address that, or would it involve taking money from another region?
If they addressed it before I was able to take funds from individuals that weren't going to spend it, I could address it. But if it's after I go ahead and I farm out what extra monies we have, there would be no way to address it.
So understanding regions would be able to do this more often than full performing regions.
Yes.
I'll just say that the Medicaid program is very similar to what we have here. We don't make exceptions. There are some exceptions for high risk children, but by and large, we don't have exceptions. We do have mechanisms for prior authorization, of course, but we try to follow our billing manual because our funds also are limited. And our adult members get $1,000 annual allowance. We try to work with that.
Yeah.
Except that dentures are not part of the $1,000.
Today, Chandra, a couple of exceptions you had one you mentioned you talked to Dr. Riley. And what did you do in that case? Did you make an exception?
Not after speaking with Dr. Wiley and finding out that if the procedure would have been done correctly in the first place, they would have been asking for an exception. So after contacting the grantee, they actually okayed that comment because it was a grantee that the dentists were not in-house.
It'd be a very difficult thing to do because you'd be actually be trying to sequester money on the back end to deal with the exceptions. I mean, as a grantee, and then you be caught in a catch-22 of sequestering money and not being able to totally spend out your allotted amount. At the very back end, you'd be playing some weird kind of catch-up. And I think that would be awkward. So then it was, I mean, just for us with the schools, we spend a lot of time and energy making sure that the procedures we have planned and completed are moving along, and the money that we've encumbered is there, and we're not overspending the grant. So that would be, I mean, it would be a challenge to leave ourselves a low basket of money in that. So I would not be.
Since lots of body candidates, we have a recommendation of approval.
How often do you ask for exceptions?
Actually, I have only been asked 3 times.
Has there ever been granted?
No.
And has there ever been discussion of limiting the funding per patient on this and leaving that not up to the grantees, but doing that through this group?
When we started this, was there ever a discussion?
And there is no limitation on funding per patient, and don't have the legislation right in front of me, but I think that might be contrary to what the legislation intent was. Interestingly, our average spending per patient after the first year was about $1,000 a patient, which is consistent with where Medicaid's is.
Make a motion.
Can you make it on a patient by patient? Evaluation? I mean, like what you did, that was an easy answer for me. Or is that gonna take it on? I mean,
That's going to be something past the funding issue that we're currently having. That would be something that if it came forward where we started doing that, you guys would be receiving emails regarding these, and the decision would have to be made by you. And so, unfortunately, especially if it's an emergency, it's not going to be in a period of time that I'm going to be able to wait 2 weeks to hear from somebody if they're out of town. I think that's my biggest fear. And we still run into some of the, concerns that were raised, their questions that we have limited funding available. Most of our grantees run out before the year is up, so we either have to be holding some funds back or we have it where the policy's not able to apply it equitably across the state as well for the trade visa. Case by case, type of cases.
doesn't sound like we can do it. So, but a motion would be, due to funding limitations, exceptions will not be made.
Second.
Favor?
Aye.
Opposed?
Aye.
Very good. So, did you want to do any type of public comment regarding the exceptions? Sure. Do we have anyone that would like to comment on that? Okay. Want to come on up, sit right here, and state your name? I guess we should have made the motion at public comment. So, sorry. So can we take the vote away? Listen. Yeah, that was my error.
Hi, I'm Phyllis Hirschfeld, and I just had a question because it seems to me that these are so rare that in our situation, I think where how this would occur would be the patient would come in with a client. They would be referred to our list of dental referrals. And at that point, the dentist would come back to us and say, they need this treatment plan. So if that was constant to what we were able to pay for under the plan at that point, we would then be, it would be no different. Anytime a client comes to us, we have no idea how much that client is going to cost us. It can be as simple as a couple of fillings, or it could be 2 sets of dentures. So it would, in my view, it would not be any different. You wouldn't have to sequester funds. It would be up to the individual grantee then to say, okay, this is a particular patient whose needs, this is what they are. And so if they grant this exception, then we will just use part of our money to pay for that. It would be no different than having a patient that you thought was going to come in with just 2 fillings, and the dentist comes back and says, no, we need to extract 14 teeth. I mean, I don't see why it would be a problem to have this ability to grant the exception if we really needed it to address that patient's dental needs. Because these patients, a lot of times by the time they come in, they have not seen dentists in quite a while, a lot of them. And to not be able to address their needs at that particular time, if that grantee has funds within their granted amount, I think it would be a disservice to the public.
I don't think we're talking about somebody that's coming in and falls within the parameters of the guidelines that we've set up. We're talking about somebody who's had something done, and they're going to need it redone sooner than our guidelines allow. We're not saying that that person couldn't get the 14 teeth extracted.
Right, but then, all right, so say that we have provided service to that to that patient 3 years before. They come back and they have some severe problems because of what happened to, or 4 years, without, sort of slightly outside of the 3-year period. And they come back and they have some severe problems. If we take that patient on and we have funds to address that patient's needs, given our budget, why would there be a problem in terms of our using the funds for that?
There's waiting lists. There's people that by you using that money again, new patients aren't going to get any treatment.
But the way we have a waiting list, it takes into consideration both the socioeconomic as well as the need for the dental service. So I think that we could probably take care of that in terms of what would be a priority under our waiting list. I'm just putting that for discussion. I just hate not to have the ability to address a patient's needs if they really might need that service, and we have the funds to be able to do that.
I'd like to make a comment, but I think I'll be okay. In terms of hygiene visits, we have some come from Metropolitan Provider Network, and it says federally qualified health center. We have dental departments that we serve situations in. We have some patients that are at high risk, so we also treat Medicaid patients as well. And, for senior dental program patients who come in, I feel that we don't really have what we see in Medicaid, the benefits, where for patients who are high risk, we can have less lower frequency of limitation than the regular patients that are at a lower risk. And it's really not an exception, but I would think that it might be great for patients to be able to receive, for example, Kaizen visits such as Prophy or SLP more often than other patients who are at lower risk. And if that can be part of a benefit guideline for senior dental programs, that would be good. I would comment on that to see if that can be okay. It doesn't have to be part of this fiscal year, but if the funding becomes more available, or we're able to wait for next fiscal year, if that can be addressed for that time. That'd be great.
So our guidelines are just approved. When will they be looked at again?
Really never, but whenever, I guess they would say, that the need for rises, and would be looking, obviously with this committee's consultation, if there's a need to make changes to the guidelines or other parts of the rules. So we have to go through that process.
So that's something to keep in mind, maybe for next fiscal year, as we do a review, that would be something to potentially change more. Because that's the evidence base, right?
Right.
In terms of budgeting for higher risk, to have more hygiene visits as a way to reduce all kinds of negative health outcomes. Especially maybe if there's a way to prioritize diabetic patients.
And so there, I wonder, and as the dentist was speaking of, is wondering if there are some guidelines that exist for higher risk patients, that we could potentially look at adopting. So maybe I'll put that out there to our providers, our grantees, and Sean can maybe do a little bit of research around that, because I think that would be really helpful for us, and this can be decide that yes, patient is profile. That might be really helpful, because that's where I guess my concern is, if we get exceptions, if it's a patient by patient basis, whose expertise will be using their time for free to try to get some help in making a decision. But if there are some benefit guidelines that we have, and Dr. Riley, as I said, and that's not really the best way to go, of course.
Certainly Medicaid handbook has been working with high-risk definitions that meet the need and meet the industry definition. And it's, we put some work into it, so I can share that with you. Certainly with adults, we're looking at concurrent health conditions that can cause, that will necessitate more hygiene visits.
So what is our guideline, what is our guidance on number of hygiene visits?
It's for the,
You can give me a procedure number. I just looked it out in my book, so I apologize.
4910.
Thank you.
I was in a school.
So that's periodontal, 4910 is the periodontal maintenance, which is 4 times per year. Those fees that are
1110. That's true.
oh, that's right, every 6 months. Yeah.
And then 2 varnishes.
Yeah, topical, topical fluoride,
Yes.
maybe 4 times a year. Any fluoride application that goes on for a little bit. In conjunction with prophylactics or preventative equipment.
But there is a provision for them to be able to go to maintenance for that year.
Yes.
So that's good.
But they have to cross the perio threshold.
Yeah.
We were kind of thinking about the restoration as caries, and thinking about the high-risk patient with the patient that had neck radiation. So, you legitimately, I mean, the point is a good point, that, keep them healthy to avoid redoing the restoration every 3 years. And marry that with the fluoride, and that would be prevented after that high risk.
Yeah. That's good.
So yeah, with that suggestion, I think looking at guidelines that Medicaid may be working on, others that you all may be able to supply them to certain high-risk patients, maybe that'd be the best way to go.
Is there anything from the private sector you can look at? The exceptions that they have?
Let's see what I can find on my
mean, the difference is we have fixed fund money, so. And maybe that could be a consideration to address your comment about, if a provider has not spent their money and does not have a wait list, maybe that's an exception for the exceptions, but.
And then sometimes when they're prioritizing the patients, maybe then this Phyllis is talking about it is those that are in greatest need of dental services, so sometimes those are the folks that are at higher risk.
I think her comment was very good, because if you change providers, think about it, you were a grantee with, one group of providers, you got treated, very high risk patient, found a gap in your preventive care, went to another provider, then you'd actually be sitting there with the scenario we're talking about. The patient, they needed dentistry, no benefit. That would be, if you let that cook for another year, you change the care parameters.
So is this something that we want to look at the beginning of next fiscal year and revisit at that time, or with what you were saying, Florida?
Our next meeting is April 11th. We can see what guidelines are available. So it takes a while for us to change our rules.
And then that'll give me time to do some research on the private sector and see what I can find.
Can we sequester funds? Should we put $5 grand, $10 grand in the bank? Just hold it until you get ready to release your, kind of that cleanup you do of the money at the end. Just, I was going to say that. Might be a big mistake. Yeah, you just create this kind of reading pot in some ways in the world, and that's what you use it for. And then if you don't use it by a certain threshold date, because you could grow into the next benefit year, then you just release it.
Our funds have to be all spent.
They have to be spent. Yeah.
So you can't roll them very quickly.
Yeah. Yeah. But you can put that person in the next benefit year just as a new employee. You can buy your time in the gap, right? Because that's really what you're trying to do.
Being an administrative consideration is you would have to process all those requests and probably encumber them through your contracts and procurement.
I think it sounds great, but
Yeah.
it's probably cost 5 cents.
Yeah.
What part of money would be.
And would they be the only one doing the program? I don't have enough, unfortunately.
And who would make the final determination? When you ask for the exception, who makes that decision? Does that entail hiring more staff, or just calling on the committee members? I think that's very helpful for them as well.
I know you just got through your hearings in the department. Is the senior dental program on the radar of any budget requests or?
Yeah, there's no budget request to increase it, but it's also not on the radar in terms of there's been nothing that we've heard in terms of it would decrease as well. So it's in the department's budget request to maintain $3 million in your funding. So we do expect that that's going to continue on, which is good. You know, the state budget is facing some pressure, but this is not the level to maintain it. But there's no opportunity at this point to be looking for additional funding.
So what I've heard is that we're going to revisit our guidelines or our rules to look at high-risk patients and what we might be able to do around preventive services for high risk, changing the periodicity of what we would do for high risk. So that's something we're going to work on in the future. What we haven't decided, and we have the motion on the table, is are we going to not allow exceptions for those 2 or 3 exception requests that we're getting to our motion. Are you ready to go again on that motion? So the motion was that due to funding limitations, we will not allow exceptions to the CBO program outside of our regular guidelines. All in favor? Opposed? That's our recommendation.
Did Jill vote?
Jill?
Yeah, can you say that one more time?
The motion is that due to funding limitations, that the senior dental program will not allow exceptions based on our guidelines. And
Okay, I'm having a really hard time hearing you guys.
Is this better?
A little bit, yeah.
Okay, I will speak louder. So the motion is that due to funding limitations, we will not allow exceptions to the guidelines for the Colorado Senior Dental Program. That's what that motion. Pardon me?
We move to not allow exceptions?
Yes.
Okay,
So if you vote in favor of
Yes.
that or against? In favor?
I can vote in favor. Yes.
Okay. Great.
And just so you guys know, I'm hoping to be there in person in the next meeting. Yeah, which will help.
All right. So thank you for public comment. That was very helpful. So our database update.
So exciting news with this. Cynthia, our soon-to-be access guru, has been working diligently on getting an access base that actually the invoices, when they are sent in, can be automatically put into this database. So we're working on a couple of issues here and there. I did send out, one of the issues we're looking at is the middle initial. I've been lax with grantees not giving me that information. Well, now they have to for the access database to populate correctly. So we're slowly getting there. I just wanted to let you guys know that it is something that we are working on. And we'll be the first to test it. I'll be using it, and once we find out that there's no errors and we're good to go, that's when we'll move it out where the grantees can get into it and do testing themselves.
The idea with that will be that the grantees will be able to look up using a client's name and birth date to see if services have been provided. It's one of the questions that have come up is, that we're moving along in time here. You could potentially have a patient who receives services and due to the benefit guidelines would be able to receive those services again, but if they're changing providers, we don't have any good way to help them know that. So we're going to provide that database to them. Some things that I've expressed is I don't want to have 5-6 years of data just out there. We will be in the secure environment we have with our grantees for every grantee to be able to see what everyone has had, but rather than an ability then for the grantees to be able to look up. So yes, Cynthia, we're working very hard on that with Chandra. So hopefully we'll have that be a solution so folks can know, especially, you know, I don't hear about it. There might be a dentures, but this program we pay for multiple sets of dentures just because the client is living on minors.
So you have a timeline for when you expect to test and then.
Yeah, so we'll let you know that it's coming very close. Cynthia's been working pretty hard. We'll send you an email to let you know. I think that we're expecting to be testing for next month, but great. Cynthia's pushes this week. But I think that's about the time it's really.
This is an access.
All right,
So I received a phone call, and it was regarding the grantee that they, teachers made, they contacted the client, they were contacted that. They kept calling and calling and calling, now the phones are shut off. And they asked if we get paid for indentures, even though they were not delivered. So I had a meeting with Alan and with InterQuest, and the way the department feels is we would really like to copy with what InterQuest is doing. Currently, what they have is if you have a patient that they just can't contact, or I'm sorry, the patient will contact them back, that they have the dentures that were completed, that they get paid for the lab only. They have to send in the receipts for the lab, and then they also need to send the dentures into InterQuest. That way, if the patient does show up, they cannot be charged on top. So basically, the grantee won't receive double payment. If the client is deceased, then they once again send in their lab paperwork showing what it costs to make them. But requirement of sending the dentures in, they don't have to do it. So this is not the way they have it set up, and it's a really good idea. So I wanted to bring it forward to you guys before we make a final determination.
Do they get reimbursed at all for any of the materials that they've had to use out of pocket?
So it would just be for what was done with the lab. Is that right?
That's great.
So impression materials and trays and all the materials that the dentist has to use in his own practice, he's not getting reimbursed for that.
That's correct. But I think what's said, they've had one, and the dentist never contacted them back regarding giving the funds.
That's great. We do have some language in there in the Medicaid dental office reference manual that talks about exceptions to losing dentures, a one-time a lifetime replacement within the 7 years of life of the denture. And those are discussed in that reference manual. But basically, if it's lost, stolen. We are looking at this because we requested a narrative from the provider, and we have recognized that we have an exception that has a lot of holes in it. People can basically say anything. So we're looking at a denture exception. But yes, we've had very low number of requests. Actually, for one dentist.
I'm not sure when the request created the policy.
We created the policy, but
Okay.
so it's just, it's a slippery slope. We all know that. We're just trying to find the right traction.
In our practices with tons of dentures, the main reason people needed to have a denture remade was pet related.
We do.
I mean, they bring the denture in, and it was obvious that, Fido had no idea.
So I'll just throw out, remind everybody, we do provide the senior dental benefit, immediate dentures. And we may find ourselves in those situations where we need something. We don't have an exception for those either. And then just sign informed consent that, yeah, these dentures are immediate, blah, 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 and they need more need for alignment or whatever. But we do not provide immediate ventures in the Medicaid sector. So sometimes I worry that immediate ventures will have a higher demand than such, they just don't fit after everything settles down.
I think this question particularly focuses about ventures where the patient or the police have never showed up, they can't contact them in order to receive it. And the grantees paying ventures been produced for the client, so they're looking for a way to get some reimbursement. So we're suggesting that we follow what the Medicaid program is doing, which is they have to produce the receipts from the lab and then they will go what the cost will have for the fee schedule, and they have to produce the insurances.
Makes sense if you have a precedent. You follow it.
So this is one off. You know, one occurrence.
What occurs so far?
How many ventures have we paid for?
Oh, that I would have to send to you. I could have told you that when I was doing the annual report.
So it's like a quarter of a percent, something like that of all the ventures that are made. This is, the request is around a quarter percent of the services rendered percent. 10%. Yeah.
I mean, it makes sense that it'd be pretty rare that the patient have to go through the process. And the business is trying to contact them, but they just aren't able to deliver the venture.
Okay, so as far as the total for last fiscal year was 1,278, and that was both full and partials.
So let's say
10%. Motion.
my question is, this is a reasonable. Yeah, so I move we accept, I move that we accept the fall of Democrats standards for accepting payment of ventures that we twice. So glad that one.
Second. Further discussion? Public comments on that? All in favor?
I,
Opposed? Very nice. Alright. So, do you have any public comment? Wishing to address the committee? Thoughts? Go on.
I just wanted to say, I was really excited to hear about the database project, because that would be a real help for us and I think most of the clients in terms of making sure that you're not getting a situation where you're providing services to patients who already have services. So, thank you for that. But I did have one question. Well, it's not a question, but we would really love to work with you, just because there's this data information that needs to be submitted on the buildings. And in an effort to really sort of use our grant dollars wisely, every time we sort of develop a system where we have been able to use our active database and then transfer it to an Excel spreadsheet, but then we can automatically populate your billing fields. And it's a very good system for us. I don't know how other providers do it, but it allows us to really effectively try and control the information and make sure that it's accurate information. And so some of that results in some of those fields being limited to either numerical values or mathematical values. And so, particularly this most recent, when we can try and populate that into that one column for the whether it's the audience or so we'd like to put the time for that. That's a reason. And so we'd like to see if maybe we can work with you in terms of seeing if we could reach a compromise or a situation where it would address your needs, but also help us out in terms of keeping the time that is needed to do the good activities.
Just to give the committee kind of background information on this. I was having issues with individuals not listing, say, when quadrants were done, which quadrant was. And even though it's supposed to be recorded per quadrant, some were not doing it. So now what I do is if I receive an invoice that the quadrant, tooth number, I mean, anything that goes in that column is not listed, it's taken off the invoice, and they need to rebill it the following month with the correct information listed. So that's what this conversation is about, just so you guys aren't lost. That's something that we can discuss.
So you're asking for the quadrant to number like
Right.
I understand today.
Yeah, let's talk.
Okay. So I don't know if that includes the whole. So I appreciate the opportunity of making it, and as usual, we're really appreciative of all the work you guys do. We really do appreciate the ability to provide dental services to seniors, and so we definitely like to see that the forward, and I really appreciate it. Thank you.
Any other public comments? Anything else? That's it for us. Okay. So our next meeting is before 2 o'clock here. Thanks, everybody. Okay.
Thank you.
It's like getting out school early, isn't it?
You need to last as long as 2 weeks like working.
Well, the good news is that your meter shouldn't have expired.
No.
Are you looking for
Yeah. Did you send that?
Just when I went through that, we're touching on
Yes.
You have to go already.
So I will,